Good morning and welcome to Health Talk, sponsored by Mon General Hospital. This program is designed to provide education on vital health topics to help you take charge of your health. You'll also be introduced to Mon General's committed physicians, allied healthcare professionals, and quality programs and services. And now, here are your Health Talk hosts, Kay Murray and Jim Stallings.
Health Talk brought to you by Mon General Hospital. I'm Jim Stallings along with Kay Murray. Our guest in the studio this morning, Dr. Bob Curtis, Medical Director of the Emergency Department at Mon General Hospital, and also Nancy Ord, Director of the Emergency Department. We just had Nancy on last Friday for the health fair, didn't we, Kay?
That's right, we did, yes.
And today's topic is heart attack care. Dr. Bob, if you don't mind me calling you Dr. Bob.
He didn't say if he did
that's
or
fine.
not.
No, that's
okay.
fine.
He reminded us that we really kind of talk about this every single year, don't we, about this time? Is it Heart Attack Care Month or anything like that, or any kind of awareness going on this month? Every month is Heart Attack Care Month.
Just so you know, the heart just never goes away, does it? It always just stays there.
Yeah, exactly. So let's talk about some of the risk factors. First of all, what is EHAC?
That is Early Heart Attack Care, which is a program that Mon General is trying to get started. We see a lot of cardiac type patients, and that's one of the big things that we do at Mon General, you know, between the emergency department and the cardiologist and the cardiothoracic surgery, sort of the continuum of care, and it might even include EMS. I mean, they're all involved in it's an integrated team approach to the care of the cardiac patient.
Can we educate ourselves enough about those risk factors? Because I could ask you, I could ask Nancy, I could ask Kay. Kay, what are the risk factors for heart disease?
Well, I guess it would be to not smoke would be a factor. It would be not eating properly. It would be proper exercise, low sodium. I think a lot of those things would play into it.
Yeah,
Did I hit any of them?
Yeah, I think a lot of those are definitely true.
Lifestyle.
You know, everybody has a genetic component. So there, you know, when patients come in, the things that I investigate are, you know, what's your family history, and sometimes it's amazing how many people in a family have had heart disease, and sometimes at a very young age. And so that's not modifiable, but there are a lot of other factors like blood pressure, smoking, cholesterol, weight. Certainly, obesity contributes to it. That, you know, are modifiable factors. So, you know, I think one of the things in terms of early care is really prevention. You know, and you know the goal should be to try to decrease those risk factors that you can, or modify them as best as you can. And exercise is a good, is also a good thing for people to be doing.
I want to know, this is a very simple question, and Nancy, maybe you'd like to take this one. What is a heart attack?
Well, a heart attack is when a little plaque ruptures inside of the artery that actually carries the oxygen to the heart. The heart pumps a lot of blood, but the arteries actually give the heart itself the blood. So what happens is a little plaque ruptures, a blood clot forms, and then the blood flow is blocked to the heart. So the heart's not getting any oxygen. It gets very, very angry. And that's one of the things that we want to emphasize is calling 911, because when the blood flow is stopped, the heart gets very angry, and it can go into what we call rhythm, where it stops and you might need shocked. So early heart attack care, EHAC, is one of the things we really want to focus on, calling the 911 so that they can start the care before you get there. They can actually transmit the EKG to the hospital. So not only do you have one of our emergency room physicians there waiting for you, but the cardiologist is there waiting for you. The whole team is there so that we can quickly expedite the trip to the cath lab and get that blockage opened.
A lot of us have some of these risk factors, being overweight being one of them, and knowing people of my age recently that died of a sudden heart attack has me scared to death. Honestly, any kind of twinge or something, I feel it pops into my mind. Oh man, just don't let me drop right here. I mean, is there any warning signs other than having those risk factors? I mean, when it comes to something, a sudden cardiac arrest, is there any time to dial 911?
I think a lot of times people have symptoms if you actually talk to people, they've probably been having some type of symptoms before they have the so-called big one, and so, I think everybody has a little denial. Is this really the heart that's causing this discomfort? And I think you've got to put it in the context. If you've got a number of these risk factors, and especially if your symptoms are maybe activity related, that would definitely set off a little red flag. And and the whole goal of this early heart attack care is to get people before they reach that point, and actually we are doing a better job of that. I mean, years ago we used to give thrombolytics for MIs in the emergency department. We don't see as many acute heart attacks. We see a lot of people who have kind of maybe borderline symptoms. It may not be their heart. And I think what I try to stress to people is, if you're worried about it, that you shouldn't be embarrassed about talking to your doctor or coming to the hospital to get it checked out, because that's really what we want to achieve. We would like people to not have a heart attack. There's so many things that can be done prior to the heart attack.
Davy Jones yesterday died, a member of the Monkees, but it was sudden, but not sudden enough where he didn't complain of feeling bad. I mean, he complained of feeling bad in the morning, was taken to the hospital, and died at the hospital. So what are some of those warning signs? I mean, you mentioned the risk factor, but what are some of those signs that we ignore sometimes?
Right. Well, the most typical one is chest pain, but
and we'll know it when we have it. It's nothing like anything else.
Well, no, I mean, it can be very different, and sometimes there's not a lot of pain, and so that's what makes it really hard to differentiate. I mean, sometimes it's abdominal pain. Their upper abdominal pain can be, secondary to your heart.
And I'm always going to have the pain down an arm?
Not always. I mean, again, sometimes you'll have radiation into the arm, sometimes you'll have radiation into the neck, sometimes it'll radiate into both arms, but not always. And, we talked about women. Women are probably less typical than men, so their symptoms sometimes can be, much milder. And, they may just feel fatigued, maybe a little short of breath, maybe a little nauseated. All those things can be signs of, a pending ischemia to the heart. And so, there's a continuum of symptoms. Some are fairly mild. There are people who come in who are having, what people call the big one. I mean, you can almost look at them and know that, it's so significantly affecting them. But like Nancy said, there are a number of arteries in the heart, and depending sometimes on which one is having the blockage, that can affect you somewhat different ways also. So I think it's real important that, from my perspective, any of those types of symptoms that occur, especially with activity, are problematic. I mean, sometimes you see very atypical presentation. I had a guy who was a painter once. He came in and said his elbows were hurting. And I'm thinking, he was just painting too much and climbing up and down the ladder. But as I talked to him, he said, I only get this pain when I go upstairs in my elbows. And that was his anginal equivalent. He was not getting chest pain. It was just pain in his elbows with activity. So the correlation with activity, I think, is a very, important one.
And we paint a picture that it's about obesity or it's about your cholesterol, but Jim and I have a friend who just recently went through some surgery for heart, and and he's very slim, very fit, and so it was very unexpected when we heard this. But the signs that he gave, something what you just said, he couldn't do the things he was doing before. He would go out to run and he couldn't. He said, I just felt so tired and I ran out of breath. And he went to the doctor, like we all should when those things happen, and it probably saved his life, Nancy.
Absolutely, and there's still a disparity between women seeking care and men in this world. And so February, we just finished Go Red for Women Month with the American Heart Association, and really highlighting women to get care, because a lot of times women come in And the only reason that they present is because they can't carry the laundry up the stairs without stopping. They get so short of breath. So, they've had a heart attack in the past and just put it off to, oh, I had the flu or I didn't feel good for a few days. And then we check them and they've had a heart attack. They ignored it. They didn't come in. And the reason they came in is because they can't keep up the workload that they're used to.
Our number is 304-296-0041 as we continue our conversation about heart attack care, or EHAC, on our show Health Talk, brought to you by Mon General. 304-296-0041.
This is Mon General's Health Talk. If you have a health-related question, call us now at 304-296-0041.
Early heart attack care. That's our topic today here on Health Talk on WHAR with Dr. Bob Curtis, Medical Director of the Emergency Department at Mon General Hospital, and Nancy Orr, Director of the Emergency Department. I do feel confident that since I see my doctor every 4 months, he's doing the stethoscope thing. Now, he's listening for the blood pumping through the heart, right? When he's holding it on my chest and back? Is that what he's doing?
Actually, what you hear, the valves opening and closing, if there's a murmur in there because one of the valves isn't opening or closing correctly.
Will he hear if there's an artery starting to be clogged? Or so
No,
you can't hear that, and the warning signs you say are like what you said, going up a ladder, pain in the elbows. It's different for everybody. So the arteries, when they clog, does it happen slowly, or is there something that comes through the bloodstream that clogs it up?
The typical thing is, Nancy said, there's a plaque that ruptures, and so when the plaque ruptures, that provides sort of a surface for a clot to form, and then the clot blocks the vessel. So it's
like broken ice on a lake or something.
It's a pretty sudden, there's a cascade that almost happens. Once that clot ruptures, it's a normal mechanism of your body if you have a cut to, stop the bleeding. So, basically what gets set off is almost like a domino effect, that the products in the blood form around that rupture and occlude the artery.
The precursor to that, though, the angina can come because the blockage does build up over time. And normally you don't get symptoms until you have about a 70% blockage in your artery. So that's when you get the angina or the chest pain that builds up to it, the precursor. And what Dr. Bob was talking about was when the heart attack happens, but the angina comes because it's narrow, and as you increase activity, the blood's not getting through. So you do get some symptoms of the angina with the blockage as it builds in there.
Okay, I'm going to throw this back on the medical world and say, why can't we come up with a test? Every time we go to the doctor, our 6 month, or in Jim's case, 4 months, there's not some kind of a apparatus that can show if we have blockages, rather than just listening, or I don't know, what else can we do to catch this?
It's really a very difficult problem, because if you think about it, everybody in society, when you're born, your arteries are totally normal. And then that's one end of the spectrum. The other end of the spectrum is you're having a heart attack, and everybody's somewhere in between there. And so the challenge is trying to sort out who is close to that end where they're going to have a heart attack. And so, for us in the emergency room, it's really getting a good history. And, if we have an elevated level of concern, then we're putting that person in and doing what's called a rule out. We'll kind of monitor their heart with cardiograms and blood work for a day, and then if that's okay, then they go for a stress test. But it's not that, we're not that good. I mean, it's one of those things where you have to have a high level of suspicion, so we have to put a lot of people in the hospital or schedule a lot of people for stress tests to make sure we're not missing those people.
What about the x-ray where we'll show the heart? And I know it's the very expensive, what's the name of it? It's an x-ray that you can...
CT angiogram.
And I know that's so expensive, but if every one of us had one of those once a year, we would know, wouldn't we?
Well, there's a problem with that, in that every study you have exposes you to radiation, too. So, CAT scans, that's another topic we could talk about, but in medicine, we're trying to look at minimizing radiation exposure. So, you don't want to do those types of things. And actually, that, when it came out, I think people thought was going to be a good tool, but I don't know that it's really taken off as much. At Mon General, we have the ability to do that, but I don't think it's done very often.
Why?
Because I think probably the cardiac cath is the better study still. It really gives you much better information, and it's more specific. So, you know, what you're doing with the CT is you're taking a CAT scan of the whole chest cavity, and, you know, it does give you pretty good information, but I don't think it's as good as the catheterization.
But you're only going to do that if we have signs of a problem.
Well, you're going to do catheterization if there's EKG changes, if the stress test is abnormal, or sometimes people have a stress test that's normal but they keep having symptoms, and we just need to look, you know, in better detail.
I would imagine a lot of people make their way to an emergency facility when they feel the chest pain, something's odd, usually can catch it in time. When is the defibrillator that's back in the hallway needed?
Again, as Nancy said, when that clot forms, the heart gets irritable. And when the heart gets irritable, you know, the heart's electrical. So when the heart gets irritable and it's not perfusing well, that electrical conduction can become abnormal and grossly abnormal. And so, you know, there are times, and that's the risk. That's why, you know, we put people in the hospital, even if we're not sure they have a heart attack. If their symptoms are good enough, they could be having one. We put them in the hospital to watch them until we can determine that, because they're at risk for an arrhythmia, and, you know, that can sometimes be treated with medicine, but sometimes, you know, it's so unstable that they have to be electrically shocked.
Can you use that thing and cause any more damage than you have? I'm wondering, if I come up to the top of the steps and like, oh my God, I'm having a heart attack, Kay, get the defibrillator off the wall. If I don't really need it, she's not going to harm me any further in any way, can she?
It's not real pleasant to have somebody shock you. It's not really.
I know, let's go try it. Let's see.
Well, the good thing is those won't shock you unless it's needed. It actually reads the rhythm of the heart.
Oh, okay.
So it's only if your heart is in that bad rhythm that you're not going to live through anyway will it cause that.
Right.
So,
like they have those at the mall.
Yeah, that's all I need is somebody at the mall defibrillating me.
But as Nancy said, that you put the paddles on, it will read the rhythm.
I'll get the 16-year-old at PAC's son. Oh my God, are you having a heart attack? Kate, who's the name on the?
It's Millie.
Hi,
Millie's
Millie.
calling in.
Good morning.
Good morning.
I wanted to know how much can you tell with the echocardiogram?
Echocardiogram, again, doesn't show you the vessels. It shows the contractility of the heart. How well is the muscle working? So if you're having a heart attack, sometimes the muscle is not pumping as well as it should. So it's helpful, but there are other reasons why you might not have a good, you know, if you have a virus that attacks your heart, your muscle may look weak. So there are a lot of other things, but we do sometimes what's called a stress echo, where we stress people and then kind of do an echo and try to see how well the muscle is functioning.
How's your ticker doing, Millie?
Well, I had it worked on about a year ago, and I had an echocardiogram this past Saturday at the health fair.
Mm-hmm.
I haven't got the results yet, but I was just wondering how much they would actually be able to tell about that.
Yeah, I think the echo is probably more useful after you've had a heart attack in terms of looking at how well the pump is functioning. We look at what's called an ejection fraction. So, you know, every time the heart pumps, how much is it actually pumping out? And so, you know, we can tell if the heart attack left you with muscle dysfunction from the echo.
So look for something in the mail that reads, if you're reading the results of your electrocardiogram right now,
Everything's
then
okay.
everything you're okay, you're still alive. God bless. We're going to take a break. Be back to Health Talk on WAJR right after this.
This is Mon General's Health Talk, providing the information you need to take charge of your health. Call us now with your health-related questions at 304-296-0041.
Dr. Bob Curtis, Nancy Ord, when should we call 911 when it comes to our heart? I mean, I don't want to call falsely, but I guess it's better to be safe than
Now,
very,
Nancy's
very
passionate
sorry.
about that. Hit it, Nancy.
absolutely. Call 911. If you feel it, go ahead and call. It is better to be safe than sorry. And like I said, we can start that treatment in motion before you even get to the hospital, when the EMTs and paramedics arrive, they can give you the baby aspirin, they can give you some nitroglycerin, they can start some oxygen, all those important things that need to happen. They can go ahead and transmit the EKG so that we can look at it in the emergency room and go ahead and activate what we call code STEMI in the hospital, so everybody knows there's this very special patient that is presented to the emergency room, and that patient gets our focus.
Thank you so much for the information today, and very good information it was, as usual, here on Health Talk, brought to you by Mon General Hospital. For Kay Murray, I'm Jim Stallings. Thanks to our guest today. Stay tuned for Morgantown AM. Kay and I back in a few minutes on WAJR.